Hi, it's Patrick Hutzel from IntensiveCareHotline.com, where we help families of critically ill patients in intensive care improving their lives instantly so that you can exercise power, influence decision making and stay in control of your and your critically ill loved one's destiny. Welcome to another video of our video series. And here you learn the 10 things you didn't know doctors and nurses are talking about if your loved one is critically ill in intensive care when you and your family are not present at the bedside. Hello and welcome to another video in IntensiveCareHotline.com's video series. And once again, congratulations on taking action in getting informed and taking control. Just by doing that, you stand out from the rest of families in intensive care, and it will give you an edge when dealing with the challenges, difficulties and complexities in intensive care. Our video series will help you find your voice, will help you taking control and power so that you can influence decision making fast in the jungle of complexities surrounding intensive care. When going through our reports and video series, you will also discover how to speak the secret intensive care language so that the doctors and the nurses in intensive care see you as equals and know straight away that you know and understand what's really happening in intensive care. In this video, you will discover what is really happening behind the scenes in intensive care, how you can speak the secret intensive care language so that doctors and nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. You'll discover the dynamics, the intrigue, the politics and the psychology at play in intensive care and how it impacts on your critically ill loved one's care. You'll discover what the elephant in the room in intensive care really is. Now, as you can imagine, when you spend some time in intensive care, if your loved one is critically ill, you get a bit of a feel for the place and its people. You get a feel for the culture in the place as well. Every intensive care unit is unique, even though a lot of intensive care units share a lot of commonalities. In more than 15 years of intensive care nursing experience in 3 different countries across Germany, the United Kingdom and Australia, I have learned that doctors and nurses are talking about 10 distinct things across all intensive care units that you need to know and that you want to know about, because they only talk about these things when you are not there, and they don't want you to know that they do talk about these things. If they did know that you knew about these things, they would be horrified, as it could well change the dynamics of the situation that you, your family and your critically ill loved one are in. You will also learn how to speak the secret intensive care language so that doctors and nurses know straight away that you are an insider and that you know and understand what's really happening in ICU. So, in order to fill in the gaps for you, I created this ebook and video for you to give you valuable behind the scenes insight so that you don't have to worry and wonder any longer of what might be going on behind the scenes in intensive care. This piece of information is another piece in the puzzle for you exercising more control, more power and influencing decision making whilst your loved one is critically ill in intensive care. So let's dive into those 10 topics. So I'll just quickly skim through those 10 topics. Number 1 is your critically ill loved one's prognosis. Number 2 is what the intensive care team says to the family or in a family meeting. Number 3 is pathology, blood results and x-ray results. Number 4 is controversial and contradicting views behind the ICU between the ICU medical team and the parent medical team. Number 5 is how managing the intensive care unit's budget might impact on your critically ill loved one's treatment. Number 6 is family dynamics. Number 7 is you and your family's perceived understanding of the situation. Number 8 is perceived quality of life of your critically ill loved one. Number 9 is end of life or the elephant in the room. Number 10 is bed status, bed movements, new admissions, and how it applies to your critically ill loved one's situation. So, let's start with number 1, your critically ill loved one's prognosis. Now, as you know, you want to get as much information as you possibly can about your loved one's prognosis. And so, you may do your own research and you may do a Google search which brought you to intensivcarehotline.com. And of course, you are talking to the doctors and the nurses in the ICU who are taking care of your critically ill loved one. What if I told you that the intensive care team only told you half the truth, or told you a distorted truth about your critically ill loved one's prognosis? Well, let's put it that way. When the intensive care team are talking amongst themselves, they usually paint a very different picture compared to the picture they are painting towards you and your family. As a rule of thumb, the sicker and the more critically ill your loved one is, the more pessimistic and the more negative the intensive care team is in their outlook for your critically ill loved one. Why do they do that, you may wonder? Well, there's a couple of reasons for that. Number 1, if they gave you false hope or too much hope and things didn't turn out too well for your critically ill loved one, their professional as well as the hospital's reputation might be at stake. It's as simple as that. But it could be for a number of other reasons, including political reasons within the intensive care unit. And once you start reading down the 10 things you didn't know doctors and nurses are talking about if your loved one is critically ill in intensive care, when you are not present at the bedside, you have a much better understanding of how things, dynamics, and perceptions interact with each other. The bottom line is that doctors and nurses will talk about your loved one's prognosis to each other when you are not there, and unless your critically ill loved one is well, on his way to recovery and almost ready for discharge out of intensive care, the intensive care team will almost always downplay the chances of full recovery or the chances of survival for obvious reasons. Now, you've already guessed that. What you didn't know is that doctors and nurses in intensive care have a very different approach when they are talking to each other when you are not there, and they are having a more realistic outlook without the worst case scenario outlook that they often present to you. Number 2, what the intensive care team says to the family or in a family meeting. Now, let's say you are going in a family meeting with the intensive care team. Now, family meetings in intensive care are relatively formal meetings, and unless your critically ill loved one in intensive care is a straightforward or soft admission with the outlook of a short and uncomplicated stay, those meetings don't take place. So, clearly, if you are having a family meeting, it's usually a pretty serious meeting with the expectation that bad news are being delivered. If the intensive care team has good news for you, they usually tell you so informally at the bedside. Once again, this applies if your critically ill loved one is a straightforward or soft admission to intensive care, and if your loved one is well on his or her way to recovery, there is no need for family meetings to be held. So, let's say a family meeting is being scheduled with the intensive care team, which usually includes the ICU consultant or ICU physician, or generally the most senior doctor on duty, usually one less experienced ICU doctor, which could be a senior registrar. It usually includes the ICU bedside nurse and or maybe the ICU nurse manager and maybe a social worker. The number of people and the ranks of people might vary slightly in each case, but for the delivery of bad news in particular, you can usually count for the most senior ICU doctor on duty and at least for one nurse to be there. And guess what? The people present in the meeting will usually have briefed themselves and what and how they are going to say things. Unlike you and your family, the intensive care team usually come prepared into such meetings. They have done those meetings before over and over again. They generally know what to expect. Health professionals in intensive care generally know what questions families ask who have just been given bad news. This also ties right in with number 1, the prognosis. The prognosis that you have been given in a family meeting may not necessarily represent reality. It all depends. You might have to dig deeper. That's why it's so important that you get as much information as possible in a limited time period, so that you and your family are well positioned, mentally prepared and mentally strong, in order for you to have power and control so that you can influence decision making. So, in summary, yes, the intensive care team usually knows what they say and how they frame it, and also how they frame the meeting. The intensive care team generally knows what to expect. The question is, what do you and how much do you know? What do you expect? What is your frame of reference? If you don't have a frame of reference as yet, you better get one quick. No matter the situation, you need to gather information quickly so that other people can't put their agenda on your plate. Number 3. Pathology, blood results and X-ray results. Now, the intensive care team obviously also talk about pathology, blood results and X-ray results when you are not there. Why is this important for you to know? Well, once again, a lot of what is said and what is unsaid when your loved one is critically ill in intensive care depends on the intensive care team's perceptions. It depends on their perceptions about you, your understanding of the situation, and also on the questions that you are asking and the questions that you are not asking. Ask the right questions and you are almost always getting the right answers. So usually the intensive care team is doing all the talking, and they discuss pathology, blood results and or X-ray results, including CT and MRI results. They discuss this at great length as number 1, it's important, but also number 2, they usually love discussing it, as those results can have tremendous impact on your critically ill loved one's treatment, on your critically ill loved one's recovery, and on your loved one's prognosis. Blood results, pathology results and X-ray results usually give health professionals in intensive care a lot of insights into the effectiveness of treatment, further treatment to come, and also your loved one's prognosis. But intensive care health professionals can sometimes also be a bit reluctant to share those results in great detail. Call it arrogance, call it time constraints, whatever you want to call it, the intensive care team tends not to share those results with you all too openly and in great detail, as they often perceive that you may not have enough knowledge to understand all of it anyway. And of course, they don't want you to ask too many questions anyway. They often couldn't be further away from the truth though. You need to, once again, ask the right questions, and you need to know where to look for answers. This site, our site, intensivecarehotline.com, is designed to give you enough insight to get answers quickly. So keep looking and keep asking. Number 4. Controversial and contradicting news between the intensive care medical team and the parent medical team. If your loved one has been admitted to intensive care, there are usually 2 teams involved. One is the intensive care team and the other team is the parent team. The parent team is the team that is looking after your loved one from a different angle, basically a non-ICU or a non-critical care angle. This means if your loved one has been admitted to intensive care with pneumonia, the parent team is very likely the respiratory team or a general medical team. If your loved one came to intensive care from a ward, he or she would have been looked after by the parent medical team on the ward. Once your critically ill loved one is discharged to the ward, he or she will be looked after by the parent medical team again. Another example is that if your loved one is admitted to intensive care with multiple trauma, the parent medical team would be the trauma team. If your loved one has been admitted to intensive care with severe head injuries, your loved one's parent team would be the neurosurgical team. Now, you might ask, Patrick, why is this important? That's a fantastic question, and there are often competing groups and therefore competing interests in a hospital. Those groups might be competing for money, resources, status, recognition, and so forth. I'll give you an example so that you understand how those competing forces might impact on your critically ill loved one's care in intensive care, and why nobody would tell you what those competing groups may talk about when you are not there. So, let's say your loved one has been admitted to intensive care with severe head injuries, and your loved one has gone for brain surgery on admission to hospital before coming to intensive care. The brain surgery was necessary because your critically ill loved one had a massive bleed in his or her head, and this resulted in high pressures in the brain that could have been lethal if the neurosurgical team hadn't operated on the brain and evacuated some of the bleeding and inserted a catheter to continuously monitor the pressure in the brain. Now, let's say after a few days your critically ill loved one is stable and the intensive care team is happy and ready to get your critically ill loved one out of the induced coma. Normally, a severe head injury always requires an induced coma for at least a few days, if sometimes not weeks, to see and find out whether your loved one is waking up and to find out whether your critically ill loved one's brain is functioning. Let's say that your critically ill loved one is not waking up as planned, and let's say that even after a few more days your critically ill loved one is still not showing any signs of improvement, and it looks like your loved one might have sustained even permanent brain damage. Usually what happens, you and your family will very likely be distressed by the slow recovery and by the lack of response that your critically ill loved one in intensive care shows. Furthermore, the intensive care team and the parent medical team, which in this example is the neurosurgical team, have often very different views of the further prognosis. As a rule of thumb, the parent medical team tends to have a more positive outlook than the intensive care team. In our example with a severe brain injury, the neurosurgical team who operated on your critically ill loved one's brain would be optimistic in their outlook, as they would suggest that the surgery they performed was successful, and they think that there shouldn't be a reason why your critically ill loved one shouldn't recover. On the other hand, there is the intensive care team who looks at your critically ill loved one and thinks, okay, we are not making any progress despite aggressive treatment. Furthermore, the intensive care team might think, okay, how much longer can we sustain treatment? Are there any other complications that we have to consider? Is your critically ill loved one developing an infection? Is your critically ill loved one ventilator dependent? Are we having enough resources to continue treatment? If so, how much longer will it take until your critically ill loved one can leave intensive care? These are the questions the intensive care team will consider. Depending on the culture of the intensive care unit and depending on the culture of the intensive care team, they may have discussions with the parent medical team, which in our example is the neurosurgical team, and the ICU team might suggest to limit treatment or to even withdraw treatment. There are usually conflicting views between the intensive care team and the parent medical team, and you often don't hear about these conflicting views. In our example, the neurosurgical or parent team would very likely oppose any suggestions about limiting or withdrawing treatment. From my experience, there are often discussions going on behind the scenes that you simply don't know about. Usually, from my experience, patients with head injuries in particular take a long time to recover, and they need to be given sufficient time in order to do so. Critically ill patients in intensive care recover in their own time. Despite medical advancement, you will find that your critically ill loved one will recover in their own time. But your loved one needs to be given that time. So, if you are in doubt about your critically ill loved one's prognosis, just simply speak to the parent medical team as well. Just request to speak to whoever the most senior person from the parent medical team is, so that you can compare views, so that you can make an objective and informed judgment yourself. Let's move on to number 5. How managing the intensive care unit's budget might impact on your critically ill loved one's treatment. Now, you might say, what does managing the intensive care budget have to do with my critically ill loved one in intensive care? Shouldn't all patients receive fair and equal treatment irrespective of the budget? That is of course a valid and important question, and the answer is that it does depend. It depends on whether you are paying for the care of your loved one out of your own wallet. If you are, well, then you will have certainly more bargaining power as you are a real and perceived customer. But even then, your critically ill loved one's case is looked at from a financial perspective. If the intensive care team and hospital administration thinks that they will not be able to reach their financial goals by continuing treatment on your critically ill loved one, the intensive care team will tell you that your loved one's prognosis is really poor, and they therefore suggest a limitation or even a withdrawal of treatment, and that it would be in the best interest of your critically ill loved one. That's why it's so important that you read between the lines, and that's why it's so important that you question things. Bear in mind, perception is everything. If you are reading or watching this and your loved one's care is covered by health insurances or by public health cover or a government scheme such as Medicare in Australia or like the NHS in the UK, then what follows is similar to what I described above with a paying customer. But because you and your critically ill loved one are not really perceived as a customer, you need to be vigilant as well. What do I mean by that? Usually, what happens in an intensive care unit is that the intensive care unit gets allocated an annual budget, and that budget is usually allocated on a projected patient activity and patient acuity. Somebody, of course, needs to manage that budget. The budget in most intensive care units is managed by the nurse unit manager in cooperation with the medical director and maybe with the director of nursing as well. It depends, of course, but the bottom line is that there is a budget that needs to be managed, and intensive care units are extremely expensive to run, as you can imagine. Now, once again, I'll give you a real-world example, and I'll give you insight in how managing the budget of an intensive care unit might impact on your loved one's prognosis, diagnosis, and ultimately their care. Let's say your loved one is critically ill in intensive care, and let's say it's your 76-year-old mother who has been admitted with a severe heart attack. Your 76-year-old mother has been previously fit and healthy, and she enjoyed going for walks every day, and she enjoyed going to yoga classes twice a week, and she also had a very active social life, meeting her friends for coffee twice a week and so forth. She has also been very interested in the family, and you and your children have been seeing her at least a few times a week. I'm sure you get the picture. So, let's say your mother went shopping and she collapsed in the shopping center because of the heart attack. Her heart stopped and bystanders were performing CPR, which is cardiopulmonary resuscitation, and the paramedics who arrived resuscitated her, and they put her on a mechanical ventilator as your mother stopped breathing at the scene. Your mother then was admitted to hospital in the emergency department, where she had a CT or an X-ray of her brain to see if she had any brain damage due to lack of oxygen to the brain during the heart attack. After your mother had the CT of her brain, she went to intensive care, where she is now in an induced coma on a ventilator and on a monitor. The CT brain showed no clear sign of hypoxic or lack of oxygen, which means there was no brain damage in the CT shown, and at this point in time it's unclear whether any brain damage has really occurred or not. So you are getting this phone call from intensive care, and you are absolutely shocked and despaired about what just happened. Yesterday you were talking to your mother on the phone and she appeared to be very well indeed. So you get this phone call from intensive care, and at first you might double check with the doctor on the other end of the phone whether it is really your 76-year-old mother they are talking about. After you have clarified that it really is your mother who has just been admitted to intensive care, you ring your brother and your sister and you are rushing to the hospital to meet your siblings there. You are going into the intensive care unit and you can finally see your 76-year-old mother, and you can hold her hand and you can talk to her even though she has been placed in an induced coma and is therefore unconscious. The bedside nurse looking after your mother is giving you a bigger picture view of what has happened, and the bedside nurse is telling you that they are cooling your mother's body temperature for 24 hours to protect her brain and her heart after the heart attack. She therefore remains in an induced coma on a mechanical ventilator, and after 24 hours they are taking her out of the induced coma to see whether your mother is going to wake up or not. The nurse is telling you that this is what will finally determine whether any irreversible brain damage has been done or not. About another half an hour or so has gone, and one of the ICU doctors is now coming to see you, and he asks you whether the intensive care team could catch up with you and the rest of your family to fill you in the events and to give you an outlook of what is about to come. You are telling the intensive care doctor that your siblings will be here in another half an hour and that it would be great if you could get an update. Half an hour later, you and your siblings are sitting in the meeting room outside of the intensive care unit with the most senior doctor and with the most senior intensive care consultant on duty and the bedside nurse present in the room. You can see a box of soft tissues on the table. You and your siblings are still shocked by just having received the phone call and the bad news a couple of hours ago from the intensive care unit that your 76-year-old mother just had a heart attack and is now in intensive care. So, the intensive care consultant is giving you an overview of the events of the last few hours, and he stresses the fact that your 76-year-old mother had a severe heart attack and that she therefore collapsed in the shopping center because her heart stopped beating at the scene. Thankfully, bystanders were performing CPR until the ambulance arrived. The paramedics took over CPR and they finally got your mother's heart beating again, and they also had to put her on a mechanical ventilator so that she could get sufficient ventilator or respiratory support after the heart attack. Because of the length of the CPR, which the ICU doctor estimated to be around 15 to 20 minutes, he is also unsure whether any irreversible brain damage has been done, because he thinks that given the length of time of CPR, as well as the fact that initially CPR was performed by bystanders, that CPR may not have been optimal, and that therefore irreversible brain damage may have been caused. You and your siblings are looking at each other in disbelief and shock. You swallow and you can't hold back your tears. The ICU consultant continues in his monologue, and he mentions that it's too early to make any predictions, and he's talking about comparing your 76-year-old mother's case with other patients he has seen and looked after over the years, and he thinks that she has a poor chance of survival, and should she survive, you and your family would have to think about your mother's expected quality of life. Furthermore, the intensive care consultant or intensivist also makes a comment that your mother is old, and that given her prognosis or her poor prognosis, she may have full treatment in the intensive care or not. The intensive care doctor explains to you what the bedside nurse has explained to you earlier, that your mother is being cooled to protect her brain and to protect her heart, and that after she has been rewarmed back to a normal temperature tomorrow, she would be assessed as if she was waking up, and if she is waking up and moving her arms and legs, and if she's starting to make purposeful movements, and if she's able to breathe, and if the intensive care team thinks she has a fairly high chance to be taken off the ventilator because she can breathe by herself, she would then continue to be treated in intensive care. The intensive care doctor goes on and says that he doesn't think that your mother would get to that best case scenario he just described, given her admission scenario and diagnosis. He continues saying that in the event that your 76-year-old mother doesn't recover, which he expects to be the case, he may or may not decide to do another CT of the brain, and that he might get a neurologist involved who would confirm the severe brain damage he expects. By now, you and your sister have been crying during the monologue of the ICU doctor, and you and your siblings are still sitting there in shock and disbelief, unable to gain back your composure and unable to even think about asking any questions as yet. The intensive care doctor continues in his monologue, and he further explains that if your mother, once she has been woken up, doesn't show any signs of recovery, doesn't make any purposeful movements, and if she doesn't breathe by herself, he then suggests that a withdrawal of treatment might be, quote unquote, in the best interest of your 76-year-old mother, who is old anyway. The intensive care doctor, last but not least, asks you whether you understand of what he just explained and whether you have any questions. Bang! Here you are. You have just been delivered very bad news. Everybody is silent for a minute. You finally gain your composure and you ask that if your mother was going to recover and survive, what her chances of a good quality of life would be. The intensive care doctor says that he doesn't think that if your 76-year-old mother was going to survive and recover, that she wouldn't be as good as before the heart attack, and that she wouldn't be able to enjoy the same quality of life than before. I stop here for a minute and I'll take you out of this fictional conversation. Okay, what have you just witnessed by reading or watching this section of the video? You have just witnessed a very insensitive meeting where the bad news about your mother, who has just had a severe heart attack, have been delivered as a matter-of-fact statement with very little empathy and with very little consideration about your and your siblings' feelings in a situation where a couple of hours before you thought that your mother was well and enjoying life. I'm not suggesting that every intensive care consultant or doctor will take a similar approach, and I have also witnessed family meetings where similar bad news have been delivered in a far more considerate and empathetic way than the one I just described. There are some fantastic intensive care doctors in this world who would always consider your and your family's feelings and concerns. The bottom line is that imagine the intensive care team would tell you that they were going to treat your mother no matter what. It would mean that it would be much harder for them to turn around and say, sorry, we stopped treating your mother because she's not going to recover. In the example I just gave you, the pre-framing of the situation done by the intensive care consultant is a pre-framing of the situation that you, without any depth and insider knowledge, would find very hard to challenge, especially in a situation that is new and that you have only found yourself in the last few hours. You are still in shock and disbelief. What the ICU consultant isn't telling you and your siblings is that he thinks that your mother isn't going to recover to the point where he thinks she wouldn't have any quality of life. He also isn't telling you that one intensive care bed costs around $3,000 to $5,000 per 24 hours, and that he and his intensive care team have a budget to manage. He's also not telling you that there are 2 more patients waiting for an intensive care bed at this point in time, because he just had a phone call from the emergency room department that they would like to admit 2 more patients to intensive care. He's also not telling you about the 22-year-old patient in the bed next to your mother who has had a severe car accident with head injuries, lung injuries and kidney failure, who has been in intensive care for 15 days, and the treatment of this patient has by far outspent the budget because of complications and the severity of his injuries. Would the intensive care team have a similar discussion with a similar pre-framing of the situation with this 22-year-old patient's family? I'm not suggesting what may be in the best interest in our example for your 76-year-old mother with a severe heart attack. What I am, however, suggesting is that you need to consider what you, your family, and your critically ill 76-year-old mother want in this particular situation, irrespective of the intensive care team's view. Here are a few things that I think you should be thinking about in case your critically ill loved one is going to recover. The things that I suggest you might be thinking about will also help you and your family to frame the situation based on your views, so that you can make your views and concerns heard with the intensive care team. So, the questions you should be asking are: would a diminished quality of life be acceptable for you, for your family, and for your critically ill loved one? If yes, what would that quality of life look like for you and for your critically ill loved one? Would it be important for you, for your family, and for your critically ill loved one to spend more time together, even if your critically ill loved one would require ongoing care? Would it also be important for you, for your family, and for your critically ill loved one to have the opportunity to die at home? Is it too much to stomach for you and for your family at this point in time to let go of your loved one and see her die, without knowing what would have happened if your critically ill loved one received full treatment and care? Do you feel like you want to continue treatment until you have come to terms with what your critically ill loved one is going through? Do you want to continue treatment until you and your family have come to terms that your loved one may not fully recover and may actually die? Do you need more time because you are waiting for other family members to come in from interstate or from overseas and see your critically ill loved one and spend time with your critically ill loved one? Do you feel like you want a second opinion from another consultant or from another doctor? There are probably more questions that you need to consider depending on your circumstances, and the list is not exhaustive. However, the questions listed above are the ones that I have found to be the most important ones that are usually considered by families of critically ill patients in intensive care. And you definitely need to ask questions based on your views, values and beliefs, and also based on the insights I have just given to you. Do not take no for an answer. Challenge the intensive care team and keep asking questions. This is the end of the first part of this video, and we'll continue with the second part of this video and question number 6. Just click below this video and watch part 2. Thank you.